Okay, well, let's open it up for questions. And Dr. Badros, I'm so happy you stuck with us. So thank you, Dr. Troy and Dr. Dispensier. And I would just encourage everyone to kind of jump in and participate in the asking of questions. So, and if you don't mind staying a few minutes over, that would be great. Um, okay, Anil is asking about an MRD question. So, is there any optimal duration to reach MRD negativity, like 1 year or 18 months after stem cell transplant? If a high risk patient can't reach MRD negativity, what's the optimal strategy? Just wait for relapse, change therapy immediately, or whatnot? I'll open
So
that. You can
I don't,
start.
I mean, I'd be very interested to hear what my colleagues have to say, but I don't think that there's really any data to suggest that the kinetics of achieving MRD negativity really makes all that much of a difference. I mean, I think the overall, what I tell my patients is I think myeloma is more of a marathon than it is a sprint. And I think as long as the vector is continuing to go in the right direction, that's really the most important thing. I've certainly seen people go down quickly and go right back up quickly. And so it is the fact that it's staying down and hopefully getting down as deep as it possibly can that really has the biggest impact on terms of how well people are going to do.
Mm-hmm. Dr. Troy, do you have any comments?
I think the ideal use of MRD really right now in 2021 is clinical trials where the primary endpoints are not usable, right? So overall survival is really difficult for many studies. Progression-free survival is becoming increasingly challenging when you go to newly diagnosed and maintenance because those patients are doing so well. So in those specific settings, MRD clearly makes sense because you can get a readout much faster, as Ivan was mentioning with his study. Now, when you leave the pristine world of clinical trials, you bring in a lot of complexity because myeloma, people like to think that this is a simple, there's two kinds of diseases, broadly speaking, hematologic disorders and solid tumors, right? Solid tumors, you keep doing scans to monitor disease. And blood disorders like leukemia, you can use blood or marrow tests. Myeloma is a blend of the both, right? And so you can have patients who have negative marrow, but have FDG avid lesions on PET. And so what are we doing changing therapies based on that one test? So this is why I think when you leave the clinical trial where you're required to do SPEP, IFE, light chain, UPEP, urine immunofixation, imaging, and then you're talking about the marrow, okay, let's have some discussions. But when you don't do that rigor, you can easily be mistreating a patient based on suboptimal information. But let's just say you were to able to do that, then you have a lot of other complexities in the real world, which Yvonne kind of alluded to. But first is how sensitive is the test? Is it 10 to the minus fourth, fifth, or sixth? That matters. Mm-hmm. Second, and equally important, is how long that's sustained. So what if you're negative at one time point, but the next marrow is positive? Because then this gets to the sampling issues of myeloma, making it different than the other heme malignancy. Because if you hit a pocket of disease, CML, you can do a blood test, right? But here you're doing a marrow, and if that pocket missed it and the other pocket hit it, again, you have discordant results. And then the last point, which I think Angela referred to, is how you get to MRD matters as well, right? So that chemo MRD may not be the same as transplant MRD. So I think when you put all of that together, it's a way of saying that MRD right now in 2021 in the real world is more of a prognostic test, not a predictive test. So when the person asks the question of what would you do, we don't really have data. We don't have data that negative patients you can stop, positive patients you need to intensify, because some positive patients may deepen response with their ongoing prior therapy, right? So you have to really think. That said, perhaps in a high-risk patient where truly high risk and I have not attained MRD negativity, sometimes I do try to intensify the therapy because there are studies showing that sustained MRD negativity, in very few, but some show that sustained MRD negative in high risk can potentially abrogate that. But I don't think the data are overwhelming. So I think it really needs to be done on a case-by-case basis.
Mm-hmm.
I'd throw in as well, MRD negativity at this point really is not an actionable, item. It is a trial question, and their trials designed, do you intensify if a patient hasn't achieved MRD? I think, in the hands of an expert, there may be particular times where a decision is kind of made, but, for the vast majority of patients, yeah, it's a happy feeling if you're MRD negative. Certainly, it may put a slightly bigger smile on your face, but in truth, nobody is expecting to change therapy unless it's on a clinical trial for the vast majority of patients. And still, patients who are MRD positive, still can do very well. But we need to really understand, what do we do with that information? And it's going to take us time to truly understand that.
Right. And I might keep you over if it's okay, so we can get to a few more questions. Kyle, yeah, what you're saying, Kyle is asking a question, just very practically speaking, for myeloma patients, like, does MRD negativity, do you use that in decision making if you were a candidate for stem cell transplant? And what I'm hearing you all say is like, well, no, not really. So,
that's a tougher, and this is really a good conversation, because I think that there is no answer. I've seen a lot of those people vote with their feet or their practice. So I alluded to trials, and even did two, about how transplants still considered a really good choice for a lot of patients up front, though again, in terms of overall survival, not transplanting, it seems like as long as you're getting really good induction, patients can do as well. If you have a patient who is MRD, they've gotten 4 or 6 cycles of something, and now you're deciding, do we do a transplant now or not? It's still a research question, but I'd be curious to hear what panelists, how they deal with that, because that's a really, really hard one.
Okay. Well,
10 to the 6 MRD negative.
Well,
But
I agree with you on. Oh, go ahead, Andre. Sorry.
Oh, no. I was going to say, my take on this is, I like to use the legal court system as an analogy, right? There's this concept of innocent until proven guilty. Where does the burden of proof lie? And I think we have made all these improvements on myeloma outcomes on the back of transplant, right? So I would say transplant, it's the burden of proof to displace transplant is on the novel therapies. And so I think I know there's a lot of patients who are very concerned about transplant and side effects, but we have to keep in mind that this is how myeloma has advanced. And so before we start throwing out an important workhorse of that improvement, we need a really good evidence for that. And the newer studies are showing that MRD negativity at one time point may not be enough. I think the Forte study in particular should give us great pause, because remember that the non-transplant arm got KRD for a year. So when you think about that, very few patients get clinical trial intensity and duration of therapy in the real world. How many people are getting twice weekly carfilzomib in the first place, let alone for a year, right? And so when you deviate from that and you do these kind of watered down regimens, and then you're making these decisions, I think you're really in murky water. And the final point I would make, the 2 points would be, one, we do think, and I think people have referred to this, we are curing about 10% of myeloma patients right now. And we may not be able to pick that up as easily because we keep everybody on therapy, because the other 90% relapse. We don't have good enough diagnostic technology, but vast majority, we actually have at Sinai, we've decided to keep an electronic medical record that we all share, all the physicians, and we're putting in our patients that are in long-term sustained remission without any treatment. And we actually have now already 50 patients who've been off therapy for 10 years, right? That's cure. But those are primarily with transplant, not without transplant. So I think when you think about that, the burden of proof, in whom have we gotten cures? So far it's with transplant. And the last point is age should be factored, because if somebody's deferring transplant and you're already getting close to 70, I strongly encourage those people to just do it, because what are we waiting for, right? With additional age can come kidney dysfunction. You'll have to reduce the transplant chemo, other medical issues that may reduce the chemo, and then you're going to decrease the benefit of the chemo. So I think in somebody who's close to 70 or over 70, if your health is good, I would say if you're going to entertain the collection, do the transplant. Where it gets a little trickier is in the very young patients. And of course, the innovative approaches, but those are my 2 cents. I think transplant shouldn't be kicked out.
I agree. I agree it shouldn't be kicked out, but it is, a tough, if you're on the fence about transplant for whatever reason, it's something, if you're MRD negative 10 to the -6, something to think about. But I would say it probably isn't a true standard by any shape. And it is a study
we
question.
Should add for high risk.
High risk, you definitely, 100%.
Right.
100% got to keep going. I don't know, Ashraf and Ivan, what do you think?
I mean, I agree. I have had these conversations with patients, and I can tell you that I've had young patients with low risk disease that are at 10 to the minus 6 and have opted to not do this, with the caveat that I'm actually checking their MRD status every 3 to 4 months. And so, you know, the downside is that they're getting frequent bone marrow biopsies, but I want to be able to pull the trigger if it just sees that there's evidence of going up. But certainly the safer approach with what we know nowadays would be to take people straight to transplant. See, Ashraf, I'm even talking about transplant now. See?
Actually, as I mentioned, that we cure about, I think 10%, maybe 15% of the patients. And I think that's a fact that should be emphasized. We have the same situation. Patients stopped Revlimid, 10 years later, they are still in complete remission. So we have this subset of patients, and it's very difficult to pick them up front. MRD is very difficult and very confusing. And I agree with all what you guys said. I think one read of MRD is not enough. I can tell you many MRD negative relapse within 3 months of MRD negativity. So I don't think MRD negativity is enough to make us stop treatment or change treatment at this point. So I think if you're on Revlimid and you're MRD negative, after 2 years, can you stop? Maybe after 3 years, there is some data coming. Maybe after 3 years, you might consider stopping it. But I wouldn't water down treatment depending on MRD results, at least at this point. And I agree with Ajay. I think transplant is the backbone of all the myeloma treatment. Those who want to say otherwise have to prove it. And so far, as I think all of you agree, nobody has proven that any other treatment is better than transplant. Having 5-6 years remission with transplant and Revlimid maintenance is not something we can achieve with any other treatment, as far as I know.
Do you ever treat somebody if they're MRD positive? Do you change treatment? Do you intensify?
So no, and that's a huge problem. So unfortunately, I try not to check MRD, but yes, and I get the results. And MRD was 100 copies, and now it's 500. What do you do? I always tell patients, we can always keep an eye on you. Most of those patients have an M spike of 0.1. They wouldn't even meet a criteria to go on a clinical trial. So unless, I know there are some debate now to start treatment when you have MRD progression. Actually, there is an editorial coming I reviewed. So I know that people are pushing for that, but I really don't think we are ready for that, at least from the data we have.
I would just add too for the MRD, we already talked about the interplay between risk and MRD, but two things we haven't mentioned are, number one, what is comprising the MRD? And I think Yvonne alluded to this, but if it's an MGUS clone, why are we beating up this patient to a pulp to get rid of the MGUS, right? And on the other hand, what is the immune microenvironment? The Spanish group did a beautiful study showing that you can have two groups of patients who are MRD positive, but if the immune microenvironment is favorable, they do just as well as MRD negative. So it is not an end-all and be-all test. It is one tool, and you have to think about the age, the risk, the bone disease, the immune microenvironment, what's comprising the MGUS. So I think MRD is really, it's in an infancy, and we really lack the scientific and biological explanations to go with it. And that's why you're seeing all of us kind of wrestling with this uncertainty.
Yeah.
No,
like,
I just was going to add something to the MGUS story, because I know that Dr. Trico years ago with Barloghi in Arkansas recommended that there is a subset of patients when you treat them and transplant them, they go back to this MGUS stage. I'm really not sure, Ivan, that that's still true or acceptable, you know, that we eliminate the malignant clone and we leave the MGUS clone. I think the story is changing, at least in my mind. So I don't see this stable MGUS for a long time in a myeloma patient who ends up with a 0.4, 0.5. The concept of VGPR equal to CR is also changing nowadays. So I don't know what you guys think.
I can tell you that what I think is that if there is evidence of immune equilibrium, or at least active immune responsiveness, and from the few patients that I showed for the data from our trial, the thing that was very surprising to me is out many, many years after their last vaccine, we're still seeing evidence of active immunity. Those are the situations in which we are seeing persistence of an indolent clone, whether you want to call it myeloma MGUS or whatever, I don't know. But it's a non-progressing myeloma clone associated with evidence of active immune responsiveness. And I think when you look at where we're seeing persistence of disease control, it's in the setting of ongoing ongoing therapy. So in the case of the vaccine, it's ongoing active immunity. In the case of IMiD-based therapy, I think it's ongoing non-specific immune activation. And I think one of the problems with CAR T cells is that we're losing that. De facto, although CAR T cells are T cells, it's a drug and those cells are disappearing. And for the most part, the disappearance of the T cells has correlated with disease progression. And until we can change that balance, we are going to continue to see a finite PFS with CAR T cell therapy.
But also
Unless you're getting,
go ahead, Angela.
no, unless they can really get everything gone, and then you don't need the
Absolutely.
persistence,
But
right?
then we're probably talking about 10 to the minus 7, which I'm
Yeah,
not even
right.
sure that we can
Sure.
really measure at this point.
Sure.
So I was going to add too, there's some questions about smoldering, and I was going to move this a little bit to that because we did a study recently taking all of our patients with newly diagnosed myeloma who had transplants, and we divided them up into those who had known smoldering prodrome and those who didn't. It's really people who had de novo versus known, with the caveat that of course most people have had myeloma, even the de novo. But what we found, what was interesting, is there was no difference in response in PFS, but having had a smoldering prodrome was an independent favorable prognostic factor for overall survival. And I think it speaks to this issue that, and that's why I think treating smoldering is such a complicated topic, because are we treating ourselves or are we helping the patients? Because if smoldering myeloma has a favorable biology, it's not necessarily an adverse factor. And I put that into the context of this MGUS state, because I think we have patients who are persistently low-level M spikes and have been stable for years. And I think it's getting more and more challenging to find that because people are chasing that to zero, right? But the question is, at what cost?
Right.
But something, I just want to elaborate on what you just said, because there was some very interesting data published about 10 years ago by Madhav Dadapkar that actually showed, and this may speak to your point, that in patients with smoldering myeloma, there is a demonstrable immune response that actually keeps the disease in check. And the minute these patients progress to active myeloma, that T cell response completely disappears. And so those may be very different patients compared to patients that are de novo myelomas that never actually had the chance of developing anti-myeloma immunity.
And actually, one of the most fascinating abstracts, sorry. Okay, go ahead.
No, I'm done.
No, but one of the most fascinating abstracts at ASH this year was actually from MD Anderson. They looked at smoldering myeloma and found that when you track these patients over time, there was actually increased checkpoint expression in both the tumor and the microenvironment at the time of progression to myeloma. So I think we really have to look at myeloma not just as the cancer, but the entire microenvironment. And I think that's why we miss half the story, because we're talking about the M spike is only telling us about the myeloma compartment. But what about the non-myeloma compartment? And I think that's really going to be essential in the future if we're going to try to get to a cure, is to understand that immune microenvironment contribution.
Yeah, because by and large, the genetic profile of the plasma cells, the myeloma cells themselves, are really not very different at all between smoldering and active myeloma. And so again, it's that interplay. It's that it's the other, that's that fine balance that's going on.
I also think one interesting aspect will be if we're going to be looking at immune profiling for patients and trying to understand in a context of MRD negative, who has favorable immune profile or who doesn't. What do you think that stands, Ivan? Do you think that's happening, or we will be doing that soon? I know some people are doing it actually in research.
We're doing that. So what we're doing is that we have a trial where we're looking at patients that achieved the CR, that got MILs, marrow-infiltrating lymphocytes, that either achieved the CR or showed progressive disease. And now we're doing 28 color multiparametric flow to look at a variety of things and to ultimately determine whether we can identify this phenotype. Because, Angela, Ajay, I mean, it is more than just a plasma cell that's dictating biology of the disease. And our focus has historically been on T cells, but I'm not sure that that's the whole story. There's the stroma, there's myeloid-derived suppressor cells, there's NK cells, there's a lot of things.
Macrophage.
And I think as we slowly dissect these things out, the whole picture will then eventually come together.
That would be nice, that patients could understand the whole picture. Okay, a couple of follow-up questions on the MRD. So if somebody had a normal bone marrow biopsy, can they use the MRD as a tool? And Sam was asking that. And then Ron was asking, does this MRD data apply to non-secretory myeloma patients? And it would, right? Because you're doing the bone marrow.
So the adoptive requires that the clone be obtained at diagnosis. So as long as they can identify plasma cells and sequence the malignant clone, they can ultimately determine MRD. Now, the problem right now is that I think their success rate is certainly not even close to 100%. You know, with our hands, I mean, my experience has been more like in the area of around 80%. I don't know what you guys have experienced, but that's been the most frustrating thing. And you know, secretory just means that the protein is being secreted into the blood. But so you could have a plasma cell and just not be making the protein and still be able to therefore measure MRD.
I would just add to that point, which is you can kind of divide people into normal secretory, oligosecretory, which is a little bit less than what you would expect, and non-secretory. There's a gradient. And the less protein you have, the more you need to depend on radiologic imaging, because you could be making false treatment decisions, both to characterize response and progression, if you're not checking. So these truly non-secretory, the marrow is almost totally unimportant. It's really the imaging every 3 to 6 months potentially to make sure you're not missing new disease, because we have those patients. And one of the challenges with truly non-secretory is getting them on clinical trials, because many clinical trials want that protein that they can track. And so often those patients have no M spike, no light chain, no urine, and their marrow is negative. So it almost is like, why are you calling them myeloma? It's because if you biopsy that one lesion, you will see it's a classic myeloma there. But that's the challenge with the less secretory patients.
Yeah, it is a big, major challenge and very frustrating for those patients, I think. Okay, a couple questions about the vaccine. So is the vaccine derived from the patient? And then Cassie and Rose want to know, will there ever be trials for high-risk patients at some point?
So the vaccine is not derived from patients. I know that there are a variety of different vaccines that are currently being tested. Ours is our 2 myeloma cell lines. And so that's why we were able to do this study in MRD negativity, because we don't need patients' tumors. So we have a vaccine that we made, it's frozen, and then anybody that's eligible could come. I think there are infinite areas where the vaccine can be explored. I think the Smouldering setting is one of them. You know, following CAR T cells is another. Following any other setting in which one can achieve MRD negativity. We opted at this point to choose the trial that I mentioned, but hopefully in the future we could expand this to a variety of other settings.
Okay, yeah, that would be very exciting. So a patient has a question about your comments about patients being cured. George is asking, do you have algorithms to tell patients, you know, whether they're cured or when to stop treatment? If you're, you know, this is such a difficult question, right?
You know, I just want to comment. Some people call it operational cure, meaning you are beyond 10 years in good remission. But I think we have seen patients relapse at 15 and 20 years. I just had a patient actually was transplanted in Arkansas 25 years ago and just relapsed at 24 years. Is this relapse of the same disease, or this is something else going on? I really don't know the answer to that. But I think maybe operational cure is a better word, that we actually, most of myeloma patients are in the older age group. If you achieve a remission for 10 years, most patients will have, as Ivan showed, you are in good remission and you die from something else. It's a very interesting graph that on one trial, survival is less than what you see with progression-free survival. But I think we are seeing those patients off treatment for 10 years. But it's never really, you cannot tell a patient you are done with this. You always check, you always keep monitoring them. So when we say cure, it's a subset that's, as Aji said, they are in remission without treatment for 10 years, but I wouldn't say you are done.
And we've always seen those patients. Even in the old days, we saw those patients without maintenance. Just, you know, there are these just amazing, you know, patients with this incredible biology that we wish we could understand, right? Like, you know, when they present, you'd say, hey, you know, it's another myeloma, but yet they can do so much better than the rest, and sort of that key, and what is actually going on there? Is it something about their clone? Is it something about their microenvironment? You know, because and that's the hard part. You know, someday I'd love to see patients off therapy. You know, there were the good old days when patients could, you know, not be on maintenance because there was nothing good to give them, and now we have Revlimid, which is good to give them. But you know, having a holiday and never having to take a medicine, for years on end is quite a treat for patients. You all know it better than any of us know it, right?
Yeah.
The way I would operationalize that question is using natural history and statistics to guide us, right? So first is, we know that the first remission is the longest for patients, and then you get progressively diminishing. So that first remission, you have to be in that category to be started to be considered for this typically, right? Then the next question is, if we think it's only 10%, you don't want to hurt the remaining 90% by hoping that these people, so you have to go with the odds of that. And then you layer onto that, somebody asked the question, who are these patients? Generally, it's not the high risk patients, unfortunately, right? So then you add to that some numbers, right? So typically induction, transplant, Len maintenance, you're getting about a 4-year remission. And then for the DARA-RD, which is probably our best regimen right now for non-transplant, again, we don't even have a median, but it's going to be around 4 years. So I would only start thinking about this cure question at around that 4-year time point in somebody who is not a high risk patient. And at that point, you're still, the statistics are not in our favor because the 90% are not being cured. But at that point, you can start asking, hey, am I treating myself or am I treating this patient? Because how long do I continue the maintenance therapy in this patient? And it's at that point, again, we don't have any data. And I think one of the things we haven't done is because, as you heard, we've been working so hard to just get people to live longer. You'd only get to ask the questions of discontinuation therapy when you've made progress in the disease, right? And it's like Hodgkin's disease is a great example. And they got so good at cures that now a lot of that work is like de-intensifying radiation duration. We're starting to ask these, the fact that we're having this question is, I think, a testament to how much progress has happened. But I think what we need to start doing is in prospective clinical trials, have these discontinuations in patients, let's say after 4 years, 5 years, and saying, okay, if you're MRD positive or negative, discontinue, don't discontinue, what happens? Because the danger is also that sometimes the sensitive patients are the ones who actually do better with more drug, right? So you can't just assume that stopping therapy is the right decision. So a lot of unanswered questions, but those numbers hopefully will guide people in at least thinking about when that might be something to consider.
Yeah, again, why you need a myeloma specialist. This is why we need you so much. Okay, a couple more questions and then we'll have to close. And if you want to answer any questions in the chat, you can. Michelle's asking, she's newly diagnosed on RVD. Should she have MRD testing? Like, what do you need at baseline, I guess, is really her question for MRD, especially that adaptive test. You do need it, right? At baseline?
So they can go back to old samples. So, I mean, you can get it at first diagnosis and some people send it, but you can get the blocks and then they can, try to get it from there as well. So have to is a strong word there.
Mm-hmm. Okay.
I think Yvonne alluded to this, but both next-gen sequencing and flow can have a failure rate of around 10%. So not every patient is valuable by both techniques. With flow, it could be very hemodilute. It didn't get to the lab in time. They didn't do enough colors. With NGS, if there wasn't enough disease or, again, technical issues. So both, if you look in all the clinical trials, there's about a 10% non-success rate with both methodologies. And it's good to have both, because if you failed one, you could try the other one, right? With the caveat that flow always needs to be done with a fresh specimen.
Mm-hmm. Okay. And then I want to ask another question. We've talked about these incredible patients who could potentially be cured or use techniques like this vaccine to have this durable long-term responses. For patients who are relapsing, even when they're trying these newer therapies, the CAR-Ts and the BiTEs, is there a role for an allogeneic transplant, or what other strategies would you suggest for those types of patients? Because they're in a really tough spot.
Yeah, so allogeneic transplantation is obviously been around for a while, and historically in myeloma has had a very high transplant-related mortality. I can tell you that here at Hopkins, we sort of pioneered using post-transplant cyclophosphamide that has dramatically reduced the mortality from the transplant itself. And so we started picking up transplants that we were primarily doing in patients that were relapsing following an autologous transplant. And we sort of abandoned it at this point because with the mini transplants, the non-myeloablative, we were not seeing durable responses. We are now talking about how to reinstitute it, potentially with a maintenance donor lymphocyte infusion or something else. And we will probably be doing that within the next year or so. But we are reserving it either for people that have really, really bad disease, such as plasma cell leukemia up front, or really aggressive relapses.
And others?
I personally don't think allogeneic transplant has any role in multiple myeloma today. I think there is very little data to support graft versus myeloma benefit. And most of the high-risk patients, especially plasma cell leukemia, relapse after allogeneic transplant. So we have abandoned that. That's being said, that some of you know, as Angela said, 20 years ago, that was my fame, that I did the first auto-allo transplant in Arkansas. And we treated 70 patients. I can tell you at 10 years, only 5 of those 70 patients are alive in remission. So allogeneic transplant does not have benefit and has no role in my mind. I don't know what you guys think.
So alternatives, I guess.
I'm going
I
to say
think
something
alternative-
controversial. So I would say that for like 99% of patients, there's like no role, or more than 99%, there's no role for allo. I don't think there's a role for reduced intensity allo. I think if a patient's young enough and they have a lot of really high risk features, it's, I think, a conversation. And I know that I'm an outlier there, and it's not like I do that many at all. But, you know, I think that there are certain patients, again, as more therapies come along, you kind of say, well, you know, they could use this, they could do that. And so you don't want something horrible to happen to, you never want something horrible to happen to a patient, but, you know, they have these other opportunities. But, you know, somebody who's not going to be eligible for a clinical trial, oligosecretory disease, young, you know, these are with really high risk disease. It's a conversation, you know, and so rare, and it's very, very controversial and heated conversations and discussions. I am definitely not a fan of reduced intensity. I think if you're going to do it, you have to go full myeloablative, and you have, you know, here and there success, but very controversial.
Well, I agree with you, Angela. And in fact, we probably are the ones out of all of us on the call that do more allos, and the long-term remission durations that we've seen have all been with myeloablative. So I completely agree with you.
I would just say from a risk benefit point of view, for the vast majority of patients, the risk is not being outweighed by the benefit. And the risks include infection, GVH. Now, the nuances are also, I would say, if the one place I think where you might want to consider is secondary cancer. So let's say somebody has MDS, a young patient with MDS and myeloma, that person you could kill 2 diseases with one. So that's, but very, very uncommon. And the other huge thing to keep in mind right now is if you do an allo, you may now be excluded from a lot of our novel therapeutic studies. So there is a big opportunity cost that comes with doing an allo now, with potentially getting excluded from CAR T and bispecifics, although they're getting better at that, I think, but I think that is just another issue to be aware of.
Yeah, but that's actually unfortunate, because if you look at the benefits of of CAR T cells in ALL, you know, an unspoken truth is that most of those patients have failed allo transplants. And so those T cells that they're actually using to make CARs are donor-derived T cells.
Right. And anecdotally, again, like Wisconsin, they do a fair number of allos. So Harry has shared that, you know, he has had really good success, you know, doing CAR T perhaps in these allo patients, even with myeloma. Again, very anecdotal, and we're kind of getting, you know, esoteric here, but never say never, never say always.
Yeah, but I think big part of what they do in Wisconsin is they do allogeneic transplant, and I think anybody less than age 50, whether it's good risk, actually most of their success is in good risk patients, that we can get them the same amount of remission considering non-allo options. I think the fact that we are doing well with allos doesn't mean we use it, because unless you prove it's an effective treatment, I think you are losing. As Ivan mentioned, most of the trials exclude patients with allogeneic transplant.
But they're patients that are ineligible for trials. And so you have like nothing, because they're oligosecretory. They're never going to get you an M spike. And you just stare and look at them, and it's like there's nothing else you know. So anyway.
Yeah, that takes us to Jenny's question. So what options are available? And I think part of it is going to be to maybe consider, I think one of the CAR T cell trials should start looking at patients that actually do not have M spike. We're seeing a lot of those patients. I'm sure we haven't talked about that, but a lot of relapse now is non-secretory relapse.
Right.
So
Gets
we
so
really
aggressive.
need to start thinking we're having those trials just looking at PET scan. I have a patient with huge PET scan and M spike of 0.5. He was able to get on the trial, but his disease is really measured by the PET activity, not by the M spike. So I think this will change as time goes by, I'm sure.
Dr. Dispensieri, can you answer a question while we're doing this?
Sure.
Mindy wants to know how AL amyloidosis is diagnosed. And I know a lot of patients can go for a long time without a proper diagnosis. So this is a really important question.
Yeah, so it can be diagnosed. You have to do a special stain. So more often somebody has to be thinking of it to make the diagnosis. And again, I don't want to get everybody all worried and weirded out, that, oh my gosh, I have one more thing. But it is, there's a test called Congo Red that can be done on the bone marrow. It could be done, take a little fat, like a little needle and sort of pinch an inch and just take a little needle of fat from the abdomen. And do a stain there and staining the bone marrow and the fat. 90% of patients who have AL amyloid will have a diagnosis.
Okay, great. And then what is the difference? Another question about this. What's the difference between AL amyloidosis and light chain only?
And they're the same. There's a lot of words. In the old days, we used to call it primary amyloid. Then it can be called AL, which is amyloid light chain, the abbreviation. So it's immunoglobulin light chain amyloid. And so, the nomenclature can get a little bit confusing for sure.
Okay, Michelle has a good question, and I can kind of answer this on by the patient advocate opinion. But she's saying, with all the new things on the horizon, how do we work on being ready, or what would be the best for us at next relapse? Do we wait for the relapse and then do research, or do we do our research first? And Michelle, I would say what you're doing today in educating yourself and hearing about this floodgate of information is what you should be doing, because like Dr. Chari is sharing all these important things about bispecifics and trispecifics and what's coming. And we just talked about transplant, and Dr. Badros was talking about the cell mods, and maybe as a panel you want to share what your opinion is. But
I will chime in on that one. I think that it depends on the person, honestly, because I think that some patients, it makes them anxious and it's just not for them. And that doesn't make you a bad person or that you're irresponsible or anything like that. But there are other people that really like the information, and it's an empowerment and it's a type of control, and then it's very appropriate and you should be doing it. So the answer is yes, it's good to learn about this, but you have to also know yourself and what's compatible with your personality and anxiety, because there are patients that these things can almost make them more anxious, and others it gives them a sense of peace and hope and all those other things. So it's a very personal decision, I find.
Mm-hmm. Okay. And then Annette is asking, what's the interval you suggest for the Congo test?
I'm sorry, what's the
time interval you suggest?
Time interval?
For you mentioned a Congo test for amyloidosis?
Oh, the Congo rate, the time interval. Well, again, some doctors will screen every myeloma patient for amyloid, as a just to do. Others will not. And so again, you do it if you suspect the disease, but again, the vast majority of myeloma patients will not have amyloid. And, the biggest danger is among those patients who are called MGUS, or monoclonal gammopathy of undetermined significance, or smoldering myeloma, because those patients are typically not getting any chemotherapy. And so what happens there is that then the disease can get worse and worse and worse. So again, doctors have to be thinking of it, and we don't always, is a problem. And so at least a myeloma patient, you're getting active plasma cell directed therapy, which is good. It's just you may have more toxicity. There may be greater dose adjustments that are required and so forth. So, yeah.
One more question that Gary had is, what's the significance of the 1Q gain, and what treatment indications do you suggest? Maybe you can answer that while I'm waiting.
Sure, absolutely. So in myeloma, 1Q definitely is now in that category of higher risk. And so there are certain algorithms, and I debated, I had all kinds of different slide sets for you guys in terms of, there are certain strategies that where everybody's exploring for high risk. You heard things, maybe CAR-T would be something to try to move up more for those patients. Often folks are thinking about using more intensive maintenance in these patients that have, higher risk disease. It's better well defined in the 17P patients and the translocation 414 patients. But the 1Q, again, it is considered higher risk. I think we don't know 100% what to do with that per se. I think it needs to be studied, and that also, even when we say something's higher risk, that is for populations of patients. We don't know, every patient is so different, and there are patients that have, quote, all these adverse features and they do fantastic. And then there's somebody who has all the good risk features and they surprise us and don't do well. So yeah, that would be what I would suggest.
Well, this is just a fascinating discussion, and thank you so much for staying over. We've gone over, but you're amazing.
We are hungry now, Jenny, so we have to go and eat. I'm sorry.
Well, thank you so much. Thank you for sharing on the bispecifics and trispecifics. Thank you for sharing on transplant and what's coming with wearables. We're doing some studies with investigators using the HealthTree tool, and we'll be doing that for wearables. So kind of keep your eyes open for that too. Thank you so much for the vaccine, and we look forward to having something like that. That would be so amazing. So we're so excited. But thank you, Dr. Badros. Thank you for hanging in there with us for the whole thing.
No, nice seeing all of you guys. Thank you.
Yes, I want to give you all a big hug, and I hope I can sometime when we see each other next. So
guys.
Yes, thank you so much, and thank you again to our sponsors for supporting us in this amazing presentation. And with that, we will wish you a happy weekend.